Perfect. Thank you again to Smith & Nephew and Dr. Philippon and Dr. Burge for the introduction. It's great to be here. It's always an honor. What I'm going to speak about today is allograft labral reconstruction. Disclosures, really no pertinence with regard to this discussion today. I think it's great just to start from the beginning and try and remember why we operate on the hip joint. And it's very simple. It's for pain. And so when we look at it, I think most of us would agree that the labrum is the primary source of pain within the joint. And unfortunately, we can also relate to the fact that we've done a lot of repairs that look very good, technically look wonderful, but unfortunately don't heal the way we want them to heal. And I looked at this in my practice, and I tried to identify which labrums or which situations put me in outcomes that I wasn't fully satisfied with. The first group is when you've had a previous labral repair. I think the tissue simply is different, and I think it's hard to salvage that situation. The second is very large labrums, very degenerative labrums, when there's cystic degeneration within the labrum or the size is just more than 10 millimeters, like you see here. I tried debulking the labrum. I've tried a lot of different things, but I think sometimes the tissue is just so unhealthy, it's hard to get adequate compression to get it to heal and really turn off and not be painful. Small labrums or ossified labrums, these are also very difficult because a lot of times when you repair them, your suture simply looks bigger than the labrum itself. And because it lacks surface area, may not heal as strong as we need it to perform well. Workers' compensation is also a very difficult population. They're very sensitive. If you don't get them out of pain quickly, they're going to be hard to get out of that spiral. For me, I've noticed that when you have a patient who has failed a previous hip scope, it's just a massive impact to them, emotionally, financially, physically. It's a huge investment. This is not a simple knee arthroscopy where you do a meniscectomy. And so it's a big responsibility when they come to me and they want to get better, and I feel that responsibility. And if we end up with a suboptimal result, nobody feels good in the end. So when I look at that one group, the revision situation, when I started my practice, I had some patients that didn't do well with their repair, and so we decided to go back in. I had 9 patients, and we did the standard lysis of adhesions, re-repair the labrum, so maybe I can touch up the bony work a little bit here and there and try and make it better. They did well for about 3 to 6 months, but unfortunately 5 of those 9 failed. It's not a good percentage. 56% failure rate was too high. In 2010, I stopped doing this procedure. What did I do instead? I did a labral reconstruction. Okay, so when you look at our numbers now, all the graphs I'm going to put up, these are going to be stated as improvements with regard to the modified Harris hip score, lower extremity functional score, a change or improvement in the VAS pain score, and their level of satisfaction out of 10 points. So you can see in this group, pretty decent improvement, 22, not anything that's awesome, but still very good. Nice improvement in lower extremity functional score, and overall pretty satisfied patients, especially with the fact that about 10% of these patients have had more than one hip scope before they got to me. When I look at my failures now, we're a lot better. 5 failures out of 137. That's a failure rate of 4%. So it's much better than what I was able to get with the re-repair. And what I started to find was that I was more reliably able to get pain-free passive motion, eliminating the guarding of the hip, eliminating the impingement test that's positive, and getting a hip that starts to feel better on exam. At the same time, I started comparing these hips objectively in my clinic to those problematic hips, the degenerative labrum, the small labrum, etc. And I really started to like the feel of these labral reconstructions more. So I developed an algorithm to move forward with. And what I simply decided was if the labral tissue was healthy and the patient was the right type of patient for this, then I'd do a labral repair. If the tissue was unhealthy or not the right type of patient, then I would do a labral reconstruction. If I got into the joint and there was more cartilage damage than I expected, I would simply resect the labrum almost completely. If the age was more than 60, I would do the same. That gets a definitive procedure with regard to the labrum, and it's been a good result as well. Everybody that I take care of gets some form of bony work, femoral osteoplasty, acetabular rim trimming. I look at this as sort of our insurance policy, okay? It protects what we do to take the patient out of pain biomechanically. So when you look at this is an example of labral tissue that I consider healthy in a young woman. We got a nice repair, and she did well. This is the labral reconstruction. This is a very powerful procedure, and I give Dr. Philippon amazing credit and support for having the ability really to do this a long time ago. The wonderful thing about this, and the thing that makes it so powerful, is that if we all agree that the labrum is the source of pain, and if we can't get it to heal the way we want it to, remove it. get rid of it. Get rid of the pain generator within the joint and replace it with a graft that should never have the ability to get innervated or become painful. If you do it well, as Dr. Neppel just said, you can reproduce normal biomechanics in the hip and normal function. And I think in that vein, we have the potential to maybe to get towards something that could be curative. Another massive advantage is that this is definitive, okay? This is the definitive hip arthroscopy and may eliminate the need for 3, 4, 5 hip arthroscopies for some patients. And if you think about it, a lot of this is just an extension of what we learned with the ACL. In the 80s, we used to repair the ACL. Another major advantage is that if you take an acetabular rim like this, you can see that we do have a pretty horrible pincer. When you have that degree of pincer, a lot of times labrum is ossified or very small. It's very hard to take it down, preserve it, do this degree of rim resection as you see here, okay, and fit it back down. The nice thing about the labral reconstruction is you can make your cup what you want it, and then you can make a labrum to fit what you need. The other benefit, I think, is in situations where you have to do a microfracture procedure. This is sort of the surprise hip arthroscopy where there's more damage than you expected. The labrum usually is pretty unhealthy, and you've got a large cartilage flap. What you can see here is that one of the main tenets that I learned from Dr. Stedman with my fellowship was that, you need to have containment. You need to have a shoulder to the area where you do a microfracture. Otherwise, your blood clot's going to thin out, especially in the hip joint. That blood clot that you generate is going to elute out of the joint most likely if it doesn't have a seal. Labral reconstruction can provide that seal, and more than likely, you will get an adequate, thick fibrocartilage ingrowth. The other thing is that it adds to the definitive nature of this procedure. I think if you have a small microfracture in a 52-year-old, and in 2 years their joint space still looks the same on x-rays, and you did a labral repair, now you say, well, did the labral repair heal? What's the problem here? What's the pain generator? At least if you do a labral reconstruction, it's definitive. This was your definitive hip scope. Make the most of it that you can, and then move forward with a total hip if that's what you need. Our results here for a very bad problem, you can see, look very encouraging. Sorry. You can see that we have a nice improvement with regard to the Harris hip score, lower extremity functional score, in patients that are satisfied for a very bad problem. My evolution with this particular procedure, I started doing artegraft when I started, and I've moved towards allograft. There's been two major advantages with that movement. The first is I've eliminated donor site issues. When you start taking bigger grafts, taking IT band in a woman especially, it can be hard for your physical therapist to get those patients well. And also now, because it's a graft, I can make the tissue or graft simply as long as I want to make it. The improvements with the technique, when I first started, this is a hard zone to work in when you're first getting used to working around the femoral head, around the origins of the anterior transverse acetabular ligament. So when I started, I typically started my graft from here and went to here. So those were 4 to 5 centimeter grafts. What I started to find, though, was that if you left that residual labral tissue down in the bottom, that was a cause for failure, and I had to revise some of those. So now what I do is I simply take the graft down to the very bottom. Okay, so I've been able to get a longer graft, and then I evolved to what I call a front-to-back technique. That just makes the procedure more reproducible so that I can get a graft the perfect length for what my needs are in that case. I think my forward button is not, oh, there it is, okay. Nope, hold on. Perfect, thank you. So in this video, you can see this is a middle-aged woman. I think she's in her mid-40s. You can see a labrum that's horribly degenerative and erythematous. It's got cysts developing within it. If you look critically, there's a little wave sign on the edge of the cup. This is not something I can repair well and had a good result with, so I ended up doing a resection of the labrum. I burred the acetabular rim to fully remove her pincer and also stabilize the cartilage. The next step for me now is to put in my anchors. I started just putting in one anchor at a time, but found that if I put them in all together, I could get them exactly where I wanted. Your anchor position is absolutely critical because this is what's going to center your graft. I then basically fixed my graft to the most anterior inferior suture and pulled it into the joint. Because it's fixed to the suture, I can utilize the pulley effect of the suture to get it exactly cinched down where I want it. I then progressively fix it from front to back. This is where you have to have 3 portals. You have to be able to maintain tension on your graft as you secure it so that you can get it fixed appropriately on the rim. You don't want baggy areas or areas where you don't have it properly tensioned. All sutures are circumferential or looped. The cool part then is you make your graft a little bit long. You never want to end short, and then you simply cut it to the length that you need. Again, you need a 3rd portal to hold the graft while you do that. The next step, I use an elite pass here, and what we're basically doing is we're passing the suture through the graft, and then ultimately I'm going to loop it around it. What that does is that just secures the end so it can't come loose. I've made a couple changes in the last 6 months. I now just use a double-loaded suture here. So one suture goes through the graft, the other one goes around it. It's sort of a Mason-Allen type of configuration so that your loop, because it's above the through, can't cut out. And what you'll see here is when you pull on the post right here, it'll pull that graft right down and it'll butt that normal posterior labrum. Side to side sutures later don't really work that well because you're not perpendicular to any of your fibers, and so it's hard to hold. I don't think it's necessary. So this is the finished product. You can see a pretty good looking labral reconstruction here. And the key is when you put the ball back in the cup, you can see that we have a perfect seal. So we've achieved our goal of protecting the lateral acetabular cartilage from a shear force, and we've achieved our goal of getting a seal between the labral reconstruction and the femoral head. So when you look at the numbers now, I've been doing a lot of these procedures. And when I look at all labral reconstructions, we have about 680. You can see a nice improvement with regard to our Harris hip score, our lower extremity functional score, and pretty happy patients with level of satisfaction. To kind of justify the movement towards me doing this more primarily, you can look at some of these individual segments. The revision procedures, they do well. 137 patients, about a 22-point improvement on the Harris hip score, 21 points on the lower extremity function.